So good morning, everyone, and welcome to the 32nd HLAA Research Symposium, Making the Invisible Visible. You know, hearing loss can be the loss of many things, but perhaps most importantly, it's the loss of connection with other people. And today's symposium addresses the powerful emotions that follow this loss and how stigma impacts on taking action and how you feel about your hearing loss and how it impacts our behavior. We're going to see engaging presentations today from a panel of top researchers in the field who will discuss the latest compelling science and spark a lot of curiosity around this topic. The sponsor for our research symposium is the National Institute on Deafness and Other Communication Disorders at NIH, and they are a major funder of our research symposiums. I think it's a tribute to HLAA that this and our fine reputation and you attending these symposiums that the NIDCD chooses to fund these symposiums, and we're very grateful for that support, which enables us to provide today's program and bring in these top scientists. Dr. Nieman, Dr. Carrie Nieman, is an HLAA board member. She is our panel moderator today. She's associate professor in the Johns Hopkins Department of Otolaryngology, Head and Neck Surgery. She's also core faculty within the Johns Hopkins Cochlear Center for Hearing and Public Health. Her clinical practice is dedicated to the medical and surgical management of hearing loss. Dr. Nieman's research is directed at understanding and addressing hearing health disparities among older adults. Her work focuses on the development and implementation of public health-driven approaches and affordable and accessible hearing health care. So I will turn this over to Dr. Nieman, and I'm so looking forward to today's discussion. Thank you, Carrie.
Excellent. Thank you, Barbara. Wonderful. Thank you for the kind introduction. Well, good morning. We have an outstanding session today. We will be focusing on stigma, an issue that is pervasive and deeply impactful. What we'll be learning about today is the science of stigma. What do we know? How do we measure it? Why does it matter? And what can we do? We have 4 outstanding panelists with us today. And we'll be dividing our session here. We have 4 lectures that we're going to be trying to fit in with a panel discussion and some Q&A. I will note that the first lecture is a little bit longer than the ones to follow to really provide us a strong foundation on which to build. So with that, we'll go ahead and meet our panelists, meet our speakers. We have Dr. Laura Nyblade. She's a public health expert, specializes in research on stigma. She has over 2 decades of experience in health research, instrument development, program design and evaluation, intervention development and implementation, and translation of research findings for rapid utilization by program implementers and policymakers. As an RTI fellow and senior stigma technical advisor, she brings her deep expertise to address conditions with a much longer history of stigma research, such as in HIV, to conditions that are newer to stigma research and intervention, such as hearing loss. She has co-led a sub-working group on hearing loss stigma under the Lancet Commission on Hearing Loss, which has developed a guiding framework for action on measurement and reduction of stigma, and has developed and published a suite of measures of deaf and hard of hearing stigma in Ghana and the US. This includes exploring the intersection of hearing loss, stigma, and ageism for people with acquired hearing loss. So thank you, Laura. We also have Dr. West. Dr. West is a medical sociologist in the Duke University School of Medicine, where she studies how hearing loss affects people's health and well-being throughout their lives. She is particularly passionate about researching the stigma associated with hearing loss and hearing devices and identifying ways to reduce it. Her interest in this area is personal. She has congenital bilateral moderately severe sensorineural hearing loss and has been wearing hearing aids since the age of 17. She is a faculty member in Duke's Department, Head and Neck Surgery and Communication Sciences. So welcome, Dr. West. We have Dr. Wallhagen, who is a professor at the School of Nursing, University of California, San Francisco, and a gerontological nurse practitioner. She teaches gerontological nursing and has worked as a gerontological nurse practitioner. And in 2006 became the director of what is now the UCSF Center for Gerontological Nursing Excellence. Dr. Wallhagen's research focuses on how older individuals and their families manage chronic illnesses and changes that occur with age. She's explored issues related to informal caregiving, diabetes, and successful aging, but for the last several decades has focused specifically on hearing loss and its impact on individuals and families. And of note, Meg is also past chair of the board of directors of HLAA. Last, but certainly not least, is Dabo. Ib is a leadership and resilience coach, a keynote speaker, and advocate dedicated to empowering individuals to rise above challenges, embrace authentic leadership, and break through barriers for personal and professional transformation. His journey from being a refugee to navigating hearing loss and leading global teams gives him a unique and powerful perspective. A former international journalist and a fellow board member of HLAA, Ib currently serves as a commissioner for the Georgia Commission for the Deaf and Hard of Hearing. He is committed to fostering inclusivity and advocating for individuals with hearing loss. So with that, I'll go ahead and turn it over to Dr. Nyblade.
Thank you. Good morning, everyone. It's such an honor to be here. As Carrie mentioned, I come from a different area of research on stigma and had the honor several years ago of being invited to co-chair a subcommittee on stigma under the Lancet Commission on Hearing Loss. And I said, I'm happy to do that, but you understand I know nothing about this area of hearing loss. I know a lot about stigma, but not about hearing loss. And it's been an amazing journey of learning for me over the past several years, and such an honor to be invited here to speak with you today and to have you show up on a Friday morning to listen. So I've been asked to basically set the stage for the panel and talk about what we know about stigma more generally in terms of how we think about it, how we define it, how we measure it, and how we intervene to actually do something about it, which I think is what we all want to end up at. So I'm a researcher, but I'm also a program implementer, and so I sort of sit or straddle the research and program and advocacy world. So why focus on stigma? I think probably all of you in this room and all of us have experienced it at some point in our lives, so maybe this isn't a question we need to have answered. But in the research world, in order for us to actually be able to advocate for work on stigma to reduce it, we really need to be able to make a case for it. And what we've learned over the years, whether it's around mental health stigma, whether it's around HIV stigma, whether now it's around hearing loss, is that stigma, which is, I'll talk more about, is a social process that really is a fundamental determinant of health and health equity. And it does this because it undermines three key determinants of health. Access to resources, we need resources to access health. Access to social support, we know how important social support is to our well-being as well as to our health. And it affects our psychological and behavioral responses, which also then feed back into our health and our overall well-being. So this work by Hatzenbuehler, this particular article, I think, is a very good one as it lays out exactly how stigma undermines health. I think it's also important, and this is a quote from Justice Edward Cameron, who's in the Constitutional Court of Justice in South Africa. And this is in reference to HIV, but I think it really reflects the reality of stigma across all areas. And that is, if we do not appreciate or understand the nature and impact of stigma, none of our interventions can begin to be successful. So whether you're a doctor or a nurse or someone who's working in social work, everything we do is impacted by stigma. And if we aren't cognizant of that and thinking about it and understanding how it's affecting what we do, we probably won't be as successful as we would like to be. So I'm going to start by talking about definitions and types of stigma. So while we all use the term stigma, we all use it every day, it often means different things to different people. In stigma research and interventions, as with many other fields, we have a veritable soup of terms, not always consistently defined or measured. This is part of the challenge for our research and programmatic response on stigma, and a key lesson learned from the HIV field, where we're not having a commonly understood and agreed upon or standardized set of measures for different types of stigma, has presented a challenge to both research to understand stigma and the mechanisms through which it affects engagement in care and health outcomes, as well as how to actually develop effective interventions to address stigma. So I'm going to start by defining stigma in a way that I have found particularly helpful for thinking both about stigma measurement, and I'll talk more about why measurement is so important, and also for stigma reduction interventions. So thinking about what is it we can do to actually change stigma and respond to the different types of stigma. So stigma is a social process. It's not something we hold or have or that is something within us. It's something we do to each other. And Lincoln Phelan, this conceptualization by Lincoln Phelan, which was, they work in the field of mental health stigma, has 4 key steps, which I think are very helpful in thinking about what is it we're doing when we're engaging in the process of stigma. So the first thing we do is we distinguish and label differences. So we take something and we distinguish it and we label it. So that's an older person, or that's a person who uses substances. So we mark someone or a group. And then we start associating negative attributes to that difference that we've marked and held up. So that person is not so smart, or that person is lazy. We start putting these negative attributes on those differences that we've held up in society as mattering. And that allows this process of separation to begin, this us and them, us and them. So a big part of the stigmatization process is that othering. It's those people over there who are different from us, and different from us in a way that we don't like, or that we think is different and maybe not so good. And so it leads us to actually almost think of people as lesser than. And in doing that, it allows us to discriminate. So it leads to status loss and discrimination. And so if you think about this process that we're engaging in, and the ways that thinking about where maybe we could intervene to actually change this process, because it is a process. In keeping with this theme of definitions, there are different types of stigma, and you might think, well, isn't stigma one big thing? So what we've learned over the years in HIV, in mental health, and now we're also learning in hearing loss, is that it's important to understand the different types of stigma, to measure them, and to intervene. So our interventions are different depending on the type of stigma. So experienced stigma is the stigma that is enacted through interpersonal acts of discrimination. So when it comes at me, I'm experiencing stigma. When I do it to someone else, which we all do on a daily basis without knowing, we're enacting stigma. So that's kind of the first part of stigma that we know is really important. And our experiences of stigma influence us in many, many ways. This second type of stigma I want to talk about is perceived stigma. So this is the perception of the prevalence of stigmatizing attitudes and behaviors in the community or among other groups, for example, healthcare providers. So it's what we think is out there. And that's a little bit different from anticipated stigma, which is our fear of stigma, whether or not it actually happens. So I might be afraid to go, for example, for an HIV test, because what happens if I'm positive and I anticipate that there'll be stigma, so I don't do it. So you might ask, why is it important to measure perceived and anticipated stigma? And it's because we know that our perceptions and our anticipations actually influence our behaviors. So what we choose to do is influenced by what we perceive or what we fear is going to happen. And then there's internalized stigma, and that's when we take all of that negative external stigma and internalize it as valid and justified. As our amazing keynote speaker yesterday talked about, he talked a lot about the power of shame. And shame is a part of stigma that is really difficult, and we need to work on that. And so you'll see there's also some of our measures are around that. Then there's secondary stigma, which is the stigma by association. So we know that oftentimes people who are caregivers, family members, people who provide health services to certain groups, they can experience stigma as well by association. Sometimes it's called affiliate stigma. And then there's observed stigma, what we see happening around us or what we hear happening. And that again is a little bit like perceived and anticipated. What we see happening to other people will influence us. What if it happens to me? So that again is something that we like to measure and helps us. And then intersectional stigma is when there's lots of different stigmas coming together, and it often deepens and intensifies the effects of stigma. So Dr. West is going to talk a bit more and give some more examples about how these different types of stigma apply specifically to hearing loss. So I think what we probably all want to know is, well, what can you do about stigma? And we've learned a lot. I've been working in the field of HIV stigma for over 25 years now with basic research, and then a focus on measurement and also on interventions. And we've learned a lot about how or what we need to do to reduce stigma. And these are what we call or what's come out of our work, which is really the key principles for reducing HIV stigma. But what I've learned over the past couple of years is that this, I think also many of these apply to hearing loss stigma as well. Now, these bubbles aren't in any particular order, but I'm going to start with the light blue bubble. So this is what we call addressing immediately actionable drivers of stigma. What we've learned over the years is that stigma can be overwhelming, and that leads to an action, right? It's this big blob, this amorphous blob, and we don't know what to do about it. And what we've learned is that there are actually immediately actionable drivers, levers that we can pull now, now, to change and make differences in people's lives while we're working for that larger social change that is the ultimate goal of a stigma-free world. And so in HIV, what we've learned is that one of the things we have to address, and we do this very concretely in different types of programs, is simply awareness. You might say awareness? All of us stigmatize, often on a daily basis, and we just don't understand that we're doing it. We don't recognize it. So something as simple as understanding when I say this, when I do this, I'm actually stigmatizing, and that has this impact on someone. Most people do not intend to stigmatize. Most of us do not want to hurt others, but we do it unconsciously. And so something as simple as building awareness can make a difference. And we do this in ways through participatory exercises with pictures, with different kinds of interactive activities, very effectively, for example, with health workers. The second thing is addressing fears and misconceptions. In the HIV world, 30 years plus into the epidemic, we still have health workers, for example, who are afraid that they can contract HIV by touching a patient. And that leads to very direct stigmatizing avoidance behaviors that marks a person living with HIV as different and different in a dangerous way. So understanding what are the fears that are driving stigmatizing behavior and then addressing those head on can be a very effective way to address stigma. And it might not be in HIV, it's very clear, that's an infectious disease, that fear is very clear. But what we're also seeing is that there's a lot of fear, at least among healthcare workers, for example, which is a space I work a lot in, is if I provide services to this stigmatized group, other people are going to assume I'm one of them. So there's a fear, a different kind of fear that needs to be addressed. So in thinking about how you develop interventions, understanding what are the fears that are driving the stigma that is being perpetrated. And then there's our attitudes and our beliefs. Those also influence our stigmatizing language, our actions, our body language, as our speaker told us about yesterday, and our behaviors. And so we need to bring those to the fore, and we need to understand how are our beliefs and our attitudes actually manifesting in the way we interact with other people, whether it's in the healthcare setting, whether it's in our communities of faith, in the grocery store. How is that coming out? And then lastly is our institutional environment. So there are things that can be done in our institutions. I work in healthcare facilities, but in our communities of faith, in our organizations that would be membership organizations that we belong to. So, and that often has to do with policies, with training, with support. So those are the actionable drivers that we know, at least in the HIV space, and which I think translate, are really core to thinking about how you design programs to address stigma. The top bubble here is what I think all of us here are probably very aware of and won't come as a surprise, is that you have to center those who are experiencing stigma at the core of the response. People with lived experience have the tools and the experience to actually lead. And so this is a key part of that. And then, but part of that is also ensuring that those who are living the experience of stigma can participate in a safe way. So in the space that I live in, it's really often not safe for people living with HIV to be public about their status, for example, because of the stigma and discrimination. So understanding that as you develop the interventions. And we've also learned that addressing the internalized stigma is very key to having the leadership from the community that is experiencing the stigma in stigma reduction interventions. And the third is then engaging our opinion leaders and creating partnerships between those who have the power to shape beliefs and attitudes and behaviors in communities and those who are experiencing the stigma. Stigma is a social process that happens in the context of power. And we need to interact and influence power as we work to change stigma. And we know that the best way to do this is not to say, don't do what you're doing, but to hold up the behaviors or the attitudes that we would like to see. The other thing is that we know from many different areas of stigma that contact strategies are a very effective way to reduce stigma. When you get to know someone and understand that they have the same dreams and hopes and aspirations that you do, it becomes very difficult to stigmatize or discriminate. So creating that space, safe space for people in power, people who are experiencing stigma, and allies to really work on this. So just to keep those in mind as kind of key principles for reducing stigma. So, okay, that comes from HIV. Does HIV have anything to do with hearing health? And we might ask, so why focus on stigma in hearing health care? And I think you all know this. It's a part of the lived experience and something that can be very impactful. And if we're looking specifically at health, we can see how stigma impacts every step of the journey to getting health. It impacts whether a person perceives a need for care. There's nothing wrong with my hearing. I don't need to have anything checked. Our desire for care, whether we actively search for services, whether we have access to appropriate and thorough health assessments. And that might not just be stigma around hearing care. That could be stigma around other characteristics or other health conditions that are barriers to accessing care. And so you can see that it undermines everything we might do on our journey to hearing care. So this was why I was intrigued to join the Lancet Commission on Hearing Loss Stigma subgroup. And as Carrie mentioned, as part of that, our task was really to think about what is it we need to do to start to start moving this forward, both in research and programs. And that was why I was asked to bring in. They were like, well, what have you learned in HIV, and can that be applied to hearing loss? And I said, well, I'm glad to jump in, but you have to have some other people on the team who actually know something about hearing loss. So I'll talk in a minute. I'll show you in a minute who was on this committee. But what we did under this group was we developed a framework to help us think about action and sort of the linkages between stigma and our behaviors and then our health outcomes. And I'm going to show you a simplified version of that in a minute. And then we also developed and tested measures for stigma. And I'll also talk about why that's so important. Might seem like a very dry topic, but in the end, if we can't measure something, it's very difficult to get funding to do anything about it or to advocate for change. So this is our stigma subworking group, and as you can see, 2 of the members are right here on the panel, and they're going to talk about this today. And we developed these measures through a process that really I'll talk about later a bit more. But I'm going to start first with our framework. And this is a simplified framework. You can imagine that for each of these boxes, we have lots of things within the boxes. But I just want you to sort of think about, as we think about how we move to action. So this group decided they wanted to call them modifiable drivers of stigma. That's what I was talking about in one of those first bubbles, about the actionable drivers of stigma, the things that you can grab hold of now, that you can push, that you can change as we work for that larger ultimate goal. And so that's where we really need to think about stigma reduction and where our interventions are going to work. The stigma manifestations are those different types of stigma that I defined. And so the stigma manifests through those different types of stigma. So we need to understand and measure what those are, and understand how they affect behavioral response mechanisms. So those things that we do, and then how that affects hearing care and ultimately hearing care outcomes, but also other life outcomes. And so this framework helps us think about where do we need to do research, but also where do we need to think about programming. So I'm just going to move to 2 of these bubbles. So the stigma manifestations are those different types of stigma, the experienced, perceived, anticipated, internalized stigma. And we know that they have an effect on our behavioral response mechanisms. In HIV, we have quite a bit of research that shows how different types of stigma influence different types of behavioral response mechanisms. In the hearing loss field, we need to start exploring that. And the reason we need to start exploring that is to really understand where do we need to put our interventions? Because if you're doing an intervention around, say, experienced or enacted stigma, who you're going to intervene with, the people doing the stigma, is different than if you were doing an intervention around internalized stigma, which would be with the people who are experiencing stigma. And we know that there are both negative and positive behavioral response mechanisms. So part of thinking about interventions is thinking about what are the positive things that we can really build on. For example, resiliency, community. These are the positive. And so the stigma affects the behavioral responses, which then ultimately affects the hearing care pathway, and then basically the outcomes, our health outcomes, our other life outcomes. So just to give you an overview of sort of the thinking of this framework and sort of to guide our research and also as we think forward to actual interventions. So I'm going to end with stigma, which might seem pretty boring. But as I said, it's really important to be able to measure stigma to catalyze action. If you can't measure something and you can't explain the magnitude of it or the scale or the dimensions, and you can't show what's happening over time, you can't really design effective programs or evaluate their progress. And we know it's really critical for advocacy. We need to be able to measure something, to measure its effects on people and on society in order to be able to advocate for policy change and for funding for interventions to do something about it. I know I'm running out of time here, so I just want to say quickly, we had a very fairly long process for developing these measures. We started with a literature review, pulled all the measures that were already out there. We then took those measures into what we called a modified Delphi process. So we spoke with lots of different groups of people who were experiencing stigma or providing services to people who experience hearing loss stigma, and had them react to the measures and give us feedback. Are we missing something? That doesn't resonate. That doesn't make sense. That's offensive. Don't ask that. And so that was a process. And then we refined it again, and then we went into a process of cognitive interviewing, one-on-one interviewing with people of the different lived experiences of hearing loss, and had them respond to the questions and then tell us what they thought we were asking about. And again, were there things that we missed? Were there things that didn't make sense? Were there things that should be dropped? And then we did a small pre-test, a small survey to just make sure everything worked. And then we went into a much larger set of surveys, which allowed us to do psychometric validation of the measures. So I'm not going to speak about the measures today. They're published. But just to say that we tried to create measures or develop measures and test them for all the different types of stigma. And we also did it for different populations. So we had populations of lived experience, those who have been living with hearing loss their whole life, as well as those who have acquired hearing loss later in life, with parents of children with hearing loss, care partners, healthcare providers, and then we had a survey with the general population. We also looked at hearing device stigma, and we also included a measure of ageism. And these measures are now published in a special supplement of Ear and Hearing, and our hope is that this will lay the foundation to start working on stigma around hearing loss and really moving the needle quickly to intervention, because that was one of the key lessons we learned in HIV. The chairs of the Lancet Commission asked me, what's the one thing you would say to us from your experience around HIV? And I said it was get the measures right from the start. Because the fact that we in the HIV field are all using different measures, we use the same terms to measure different things, has really set us back in our ability to move the field forward to actually change stigma for people. Thank you.
All right. Hi, everyone. Are we good on hearing me? Hopefully. Great. Okay. So I'm Jessie, and as Dr. Nieman said, I'm coming to you today both as a researcher who studies hearing loss, as well as a person with hearing loss. This photo is from the 10th anniversary of when I started wearing hearing aids. So it took me 10 years from the age of 17 to actually really start to acknowledge my hearing loss and my hearing aids. So I went to the American Girl doll store and got my doll a pair of her own hearing aids. And this was a major step for me in acknowledging my own hearing loss and journey with hearing. Because like so many other folks with hearing loss, I've really struggled with the stigma related to it. And my personal journey with hearing loss has led me to a career in which I study the health and well-being of people with hearing loss and how to improve their health outcomes. My interest is really in helping people with hearing loss live their healthiest and best lives, and I believe that stigma is a major barrier to this. So Dr. Nyblade talked about stigma broadly, and I'm going to transition us to talking about hearing loss stigma specifically. So hearing loss stigma refers to the negative or unfair beliefs surrounding hearing loss that lead people to view it as abnormal or undesirable. In turn, this stigma can cause people with hearing loss to be perceived as having less social value than people without hearing loss. And in reviewing the literature, we see that there's quite a bit of evidence documenting that hearing loss is stigmatized and associated with experiences of discrimination. If you look at the words in this bubble, you'll likely see some familiar ones, that hearing loss is associated with being old or unfriendly or rude. For me, the one that really hits home is unintelligent. So when I go to give presentations, I really worry that someone in the audience is going to ask a question and I'm going to have to ask them to repeat so many times that they're going to either think I'm unintelligent, don't know how to answer the question, or they're just going to get really frustrated with me from having to repeat so many times. So we know that this stigma is out there, but as Dr. Nyblade was saying, when it's all jumbled up, it's hard to quantify the extent to which stigma exists, how it's showing up, and who is most impacted by it. So until we can quantify it, we can't really intervene on it. So rather than thinking about hearing loss stigma as one umbrella thing, we break it down into these different types of stigma, which is what Dr. Nyblade was showing us on one of her slides. To make these a little more concrete, I'm going to show you some of the items that comprise the questionnaires that the Lancet Commission on Hearing Loss developed for each of these 4 types of stigma. So each item in the anticipated stigma scale relates to wearing a hearing device. Questions here ask whether you worry that others will be reluctant to talk to you, will think you're older or less attractive, will tease or make fun of you because of your hearing device. And these are all examples of expectations or fears that one will be judged or treated differently in the future because of hearing device use. The internalized stigma scale includes items like feeling embarrassed, helpless, or insecure because of the hearing loss. So these are all negative ideas that someone with hearing loss has accepted as true and internally applied to themselves. The perceived stigma scale asks people with hearing loss to report their belief or awareness of the negative attitudes that other people hold toward hearing loss. This includes thinking that others believe hearing loss makes a person less intelligent or unfriendly, or that people are uncomfortable when they are around people with hearing loss and don't want to date them. Finally, the experience stigma scale asks how often you're shown less respect, get excluded from activities, or get made fun of for having a hearing loss. It also asks about how often people get frustrated with you or are unwilling to communicate with you because of your hearing loss. And so how does knowing these different types of stigma help us from a research perspective? Based on a very simplified version of the framework that Dr. Nyblade introduced, stigma affects behavioral responses, which have a host of downstream effects for individuals. For instance, people with hearing loss tend to withdraw from social situations, as you all are probably aware, even when they're with family and close friends, which can lead to social isolation and loneliness. Hearing loss is also linked to anxiety, poorer quality of life, and listening fatigue, which describes how physically, mentally, or emotionally tiring listening can be. To put this in a little bit of context, you're all here right now. You're experiencing listening fatigue right now just in general because listening to people talk is tiring. But when you add on the fact of a hearing loss, it's exacerbated because it's not a clean or clear input. In the literature, we also see that hearing loss is associated with lots of negative physical health outcomes. Hearing loss increases the risk of dementia, poorer physical functioning, diabetes, post-operative complications, falling, and falls-related injuries. And there are a couple of pathways through which the different types of stigma can lead to these outcomes in people with hearing loss. So for example, let's say there's an individual who develops hearing loss and they anticipate that they're going to be viewed as old and weak if they acknowledge their hearing difficulties. To avoid this judgment, they might deny their hearing loss, their hearing changes, and convince themselves that their hearing just isn't bad enough to need help. And this denial may lead them to the decision not to seek hearing aids. But without hearing aids, communication becomes more challenging in certain settings, like maybe an exercise class. So the person may stop attending their usual yoga class because they struggle to hear instructions. By avoiding these classes, they miss out on both physical activity and the social connections that come with it. And over time, this can lead to negative health outcomes, including physical decline from not participating in physical activity and various forms of social isolation from not hanging out with people. In the case of internalized stigma, Let's say a person feels so ashamed of and insecure about their hearing loss that they feel like they're a burden to others. So rather than advocating for their communication needs in conversations, they avoid asking for repetition and clarification. This makes it more challenging for them to follow the conversation of topic at their usual book club, so they stop going. As you can probably imagine, this could lead to increased loneliness and emotional distress because they've lost their connection to a group that was once a very important social setting for them. But at the same time, the reduced cognitive stimulation from reading new books in the book club could raise the risk of cognitive decline. On the perceived stigma pathway, a person may believe very strongly that others think individuals with hearing loss are difficult to communicate with. This person may become hyper-aware of others' reactions to them in communication settings and may anticipate being judged or treated with impatience. This fear may become so strong that the person with hearing loss starts avoiding communication-intensive environments where misunderstandings are likely to occur, such as a healthcare visit. And I think you can all understand that avoiding medical care when sick or not managing current conditions that exist will then lead to increased health risk or poorer health outcomes. And then finally, an employee may experience stigma in the workplace when they request reasonable accommodations, but these get denied. This lack of accommodations can lead to communication barriers, so the employee then may have a harder time following the conversation in meetings and understanding instructions that come up during those meetings. The employee then might avoid contributing during meetings and instead sit through them in silence. Such withdrawal can negatively affect mental health by causing feelings of frustration, embarrassment, or incompetence, but it can also have really detrimental consequences for job performance and career advancement if this lack of participation leads to negative performance reviews and being fired from the job. So as you might gather from these examples, it's important to understand the type of stigma that's being experienced because each type creates a different pathway of problems, and each pathway will require a slightly different intervention to combat it. Put another way, we can't really develop an effective one-size-fits-all hearing loss stigma intervention, but we can develop interventions to prevent or reduce these different types of stigma experiences. And to start this process, as Dr. Nyblade mentioned, the stigma subgroup has developed a series of surveys that can measure the prevalence of these different types of stigma among people with hearing loss. And once we get the data on the types of stigma that are most prevalent among certain groups of people, we can use that information to develop effective interventions. And with that, I'll end here with leave you my contact information. You're welcome to reach out to me at any time with questions or comments. Thank you.
Hi, good morning. Can you all hear me? Great. Well, it's always a problem when you're going after several excellent talks, but I'm really honored to be part of this panel. And I'm taking you in a slightly different direction, hearing loss and hearing aid stigma in the healthcare family context. And I really became interested, and this is going to be sharing some of the manifestations of the types of stigma that have just been discussed by both Dr. Nyblade and Dr. West. But I think it impacts healthcare very directly. And I got involved partly in hearing loss. I was very interested in it, but I realized from a healthcare provider standpoint, no one understood hearing loss. And I've been trying over the years to get people to really understand the experience of hearing loss and pay attention to it. So what I want to do first is just let you know that I have no disclosures, although I do acknowledge the grant funding for the kinds of data that I will be sharing with you this morning. What's the problem? Despite multiple efforts in terms of new technologies and so forth, efforts to get broad, sustainable, and I emphasize sustainable, approaches to promoting communication access in healthcare settings has not been successful. So the question can be raised in terms of what role stigma and hearing aid stigma may play in this role. But we also do know that there's been really poor research in this area in terms of poorly understood. So what I'd like to do in the brief time that we have together is sort of move and discuss stigma in the context of this dynamic triad, if you will, of the person with hearing loss, their family, the healthcare provider, and the health system. And I'm doing this partly to sort of share manifestations, and some of these manifestations will be very familiar with you, but I'm sharing them for specific reasons to get at specific points about the issue around self-advocacy in healthcare and the need to get hearing screening embedded in the normal workflow of the healthcare system. So I'll be talking about the barriers in a healthcare system because I do believe that in order to do the interventions that we've talked about, we need to understand the constraints of the systems within which we're working. And then turn to identifying strategies because I think this is potentially an optimal time to get some attention to hearing screening and hearing loss in the healthcare system. So first, this is my triad, if you will, and it occurs in the social context. You can't take that away, but it is all these individuals interacting with each other. So my first focus was talking about some manifestation of hearing loss on the receipt of quality palliative care. And palliative care is a very interesting place to focus on. I work with a lot of palliative care practitioners, and they keep having training about good communication strategies. And so I would ask them, well, do you train about hearing loss? Do you ask about hearing loss? And the truth was, no. So I worked with some colleagues, and we did a survey. We did a survey of practitioners. This was 510 practitioners. 91% reported that hearing loss had some or a great impact on the quality of care they provided. 88% reported that a communication problem with a patient, and 56% reported a communication problem with a caregiver. Those who responded to some open-ended questions, the themes fell into three big, or a number of big categories, but three that I want to talk about specifically today include compromised symptom assessment, misinterpreting cognitive status, and left out of goals. Now, you can reflect on that from some of the talks before in terms of these issues. When we looked at compromised symptom assessment, what the practitioners would say, they noted that the symptom assessment was often ended early or not complete. For instance, one person said, it's difficult to assess a person accurately when they have hearing loss. But another acknowledged specifically, I tend not to do a full symptom assessment when confronted with the problems in communication. And you can see in palliative care how critically important that is. Because technically, palliative care is to talk to individuals about goals of care and have them and do symptom management. If you don't get at the symptoms, you don't manage them very well. In terms of misinterpreting cognitive status, this is an area that's always of concern to me, and it relates to both stigma related to hearing, but also stigma related to persons who are older. This person noted a patient can be assumed to be disoriented if not answering the questions correctly. That echoes something that Dr. West mentioned about fear of being interpreted as being not as intelligent because you need to have the questions repeated. Another person said prior to having this communication board, everyone on the team thought he was demented, but he wasn't. And another elderly man whom people had assumed had dementia, he did not. He was very belittled. The impact on patients is significant if you don't pay attention to and understand that the person has difficulty hearing. The final area that I want to just mention is left out of goals of care. This person talked about self-determination and decision-making can be more difficult. They may defer to their family members when they can't hear the options. And the patient could not hear well. The caregiver spoke in his behalf, attempts to communicate directly with the patient. Finally, just saying the patient was not able to participate fully in decision-making because people thought they were confused. These are very important things in terms of, again, the efforts to get hearing loss embedded in the workflow so it's not even thought about, it's just done automatically. Well, what about primary care? The big issue here that I want to emphasize is that in primary care so often, you're never asked about your hearing status. And it's a little bit long, but I use it for a specific reason because I want to point out several things in terms of manifestations, but also our own understanding or assumptions when we go into an office. This individual says when they were asked about whether they had been asked, not that I recall because I never came in from issues with my hearing, but the truth is if you're talking about all your other issues, you've got to be able to hear. So the assumption is really incorrect. But then he goes on to say, I didn't get my hearing aid here, I think maybe way back. But then he goes on to note that really and truly it was he himself who raised the issue because he needed the hearing aid for work. So it wasn't addressed by the healthcare system. And then he goes on, I'm not bashful about saying, could you please repeat? These individuals in this study were very willing to self-advocate, but I'd like to argue that self-advocacy itself can be a bit of a problem in the healthcare system and what it means for the individual as well as the setting, because many people don't. Also, when individuals even raised it, they didn't always get the accommodations. Unfortunately, I've ended up in the ER a few times and I have coronary artery issues. I'll tell them, I'm deaf in the right ear, and there's not a whole lot of attention to it. But again, even when they're mentioned, and he talks several times about not having his wife able to come in terms of being able to hear, having the other ears. And then the one person, the piece that's so critical to me is missing information without knowing it. The person mentions that, do they clarify, tell them you have difficulty, I do more now because I need to hear. In the past, point where just tolerate it, letting it slip by. So often we let it slip by. The other problem is, though, that there are barriers to advocacy. This individual acknowledged that they felt funny about raising the issue, even if they did, because they didn't want to acknowledge that they didn't hear. And I would say that this raises, again, the issue of dependence on self-advocacy. Because to advocate means to speak out, to recommend, and it's a major part of the disability community, and we believe in self-advocacy. But there's some issues. And I really appreciated the fact that this Charlotte Hyde, who does don't ask me why she calls it the limping chicken, but she does a blog in the UK. And she mentioned that there are 3 types of people. Open, they have happy to talk about their hearing loss. Well, happy might not be the best term. Anxious, those who are not comfortable discussing it, but unaware, those who don't know. And those are the individuals that are especially raising issues in a healthcare system when you need to know the information. But she goes on to note that the constant self-advocacy can lead to burnout. I begin to feel anxious about telling people I'm deaf or asking someone to communicate with me in a different way. I end up forgetting parts of my script, leading to further mop-up conversations in the future. And then she says, hearing people do need to be reminded. They start out well, but soon they forget. They speak clearly for a few sentences and then they taper off into a mumble. It's a perpetual internal battle between, am I making too big a deal of this, or I deserve access. And that, to me, is something that we're putting a big burden on individuals who come into the healthcare field. So yes, we need to have self-advocacy, but it should be shared. However, now I want to turn briefly to some of the barriers, because first there's a power differential, and people talk about the problems of feeling about time and other pressure issues, and also the competing demands. Because if you look at the healthcare system itself, they are demanded to deal with multiple problems, trainings and this kind of assessment, and they also have to deal with what are called never events, which are things like falls and infections. So they spend a lot of time on those because they get gigged in terms of financial payments. And when you look at the provider themselves, the providers, our primary care providers, are asked to do all kinds of screenings, from depression to falls to social determinants. One person said, they ask me if I'm safe at home, they don't ask me if I can hear at home. And that's true. We ask about all these other things, but we don't ask about hearing because of the time pressures. So it needs to be built into the system. Well, I would say, this getting back to the context, just saying that there's the stigma aging in the person, the healthcare provider has theirs, they have time, they have health conditions to deal with, the cost factors, and then the person has to be open to need to know to do self-advocacy. So is there a way forward? And I would say that right now there is maybe a prime time to actually integrate hearing loss into the healthcare system. And I believe it can be the age-friendly health system. Why? The age-friendly health system was an initiative by the John A. Hartford Foundation and other groups within the healthcare field to really improve the care of older adults. And I would say this should be across the life spectrum. It shouldn't just be for older adults. It's applicable. And what they have is it calls these 4 M's. And it looks at what's critical is what matters. So you start out with what are the goals of the individuals? What do you want to keep doing? What do you not want to lose? And then medications should be looked at in terms of the impact on what matters. Meditation, we know that we need to think about keeping people cognitively, like does the medication affect that or anything else? And mobility. So these 4 core areas are being integrated in many healthcare systems in terms of age-friendly. But this is now going to be promoted even more because is it feasible? And I would say this is the CMS age-friendly hospital measure. Just recently, the Medicare Hospital Initiative, this falls under what's called the Quality Reporting Program, which is a pay-for-reporting program for acute care hospitals. What it does is it actually pays the hospitals a benefit if they report that they did certain things toward quality care. And just recently, they did a new age-friendly hospital measure that's designed to improve the care and outcomes. And it really does, and people will be gigged on this if they don't meet them. They have financial penalties. And the areas fall into the age-friendly system, which means eliciting goals of care, responsibility for medications, et cetera. This is just to show you it's the domains. You can't read all that, but they have domains that they have to say, yes, they did this, or no, they did not, in each of those domains to meet the criteria. Why is this such a leverage point? Well, I think we can all argue hearing is essential in healthcare system and in the age-friendly healthcare system. We know having to communicate is critical. So in terms of what matters, to communicate goals of care and personal values, you have to be able to hear. Medications, to understand the regimen. Mentation, we know that hearing loss affects cognition and is a risk factor for delirium, which is critical in hospitals. And mobility, hearing loss is a risk factor for falls. So using our understanding of hearing and how it relates to healthcare, integrating hearing screening into the system, it's just part of the workflow because you have to know the person can hear you to do anything in healthcare. And hearing is a health piece. Hearing healthcare is part of healthcare. So I would say that in summary, I think persons with hearing loss do still need to advocate in their environment, but shouldn't bear the full brunt of their hearing needs. Leveraging, I think, the hearing healthcare friendly or the age-friendly health system with this new CMS age-friendly hospital measure may facilitate integration into the health system and making it part of the workflow, which is critical because adding more doesn't work too well. Research is needed on strategies on how best to do this. We do need to integrate. I do think that integration can minimize and mitigate the stigma because it's just part of healthcare and the negative impact. And people don't have to raise it necessarily, but it's asked about them. And then research, we do need to better understand stigma, which gets back to all the measures that we have here today that I think will be used in the future to improve care. So with that, I really want to thank you very much.
I'm so grateful for the invaluable insights shared by my fellow panelists and researchers here today. And I'm honored to be part of this panel and deeply grateful and thankful to the HLAA and all the organizers of this research symposium, because stigma is more than a concept. For many of us, it's personal. More than a decade ago, I walked into the clinic on campus at Towson University for allergy symptoms. While I was there, the doctor mentioned hearing screenings happening elsewhere on campus. I'd never had one before. I wasn't worried. I had no symptoms, or so I thought. And I was curious. I wanted to learn about this hearing screening. When I arrived at a hearing center, they handed me a headset. Raise your hand when you hear a beep, they said. I nodded. And so, I waited. And I waited, right? I see you all are familiar with that. A whole minute passed. Not a single sound. That silence, it changed everything. Another test confirmed something I never expected: bilateral sensorineural hearing loss. Something that I had lived with for years unknowingly. I had no language for it, no roadmap. Didn't even understand what it meant. Just shock and silence. What I didn't know then was that of life's hardest truths, sometimes stigma hurts even more than the diagnosis. For years, I wore a mask. Behind it, stigma, shame, especially as a young man wearing hearing aids, isolation, and the shaken sense of identity as I began to doubt myself. But I later learned this wasn't just my story. It represents the silent journeys of so many. How many of you have ever tried to hide your hearing loss or even felt someone didn't understand? Yeah, I see a lot of hands. Yeah. You're not alone because there is a community ready to work with you. And today, we're going to turn silence into strength by first understanding what stigma really feels like. Because stigma, it doesn't always scream. Sometimes it whispers. A few months into a new leadership role, I emailed the global team that I work with, sharing my hearing loss diagnosis. I wanted to be transparent to help them understand how to best communicate with me. Later during break, one of my colleagues walked to me and said, "Hey, Ibs, are you going deaf?" He probably meant well, but he didn't understand. And it hit me hard. It confirmed the fears I hadn't voiced out. That I'd be judged, that I'd be seen as less capable, treated differently. So I pulled back. I went quiet around others and within myself. That moment and what followed is why I care so deeply about how stigma shows up in the workplace. But it doesn't end there. Stigma follows us at home, into our communities, into our identity. Whether you're working, whether you're retired or newly diagnosed, you've probably felt its weight. So let's talk about the invisible weight and how we begin to lift it. We often think of stigma as something external. But most of the time, the impact is silent, is internal. It shows up in everyday moments, feeling ashamed to wear hearing aids, even though they help. Shame around hearing aids is more common than you can think. A Forbes Health survey found that nearly half of adults with hearing loss believe there is still stigma attached to wearing hearing aids. And that feeling is even more common among the younger population, younger adults. I remember the first time I wore my hearing aids in public. I kept looking over my shoulder. Are people staring at me? What are they thinking about me? Judging? Do they think I'm broken? These are all emotions that I was feeling, and I was hurting on the inside. That's the weight of stigma. Not just emotional, but mental and spiritual. A weight you carry even when no one sees it. For me, it wasn't just one moment. It was years of masking, staying quiet, when I really needed to be heard. So if any part of this feels familiar, that weight was never yours to be carried and is never yours to be carried. So let's talk about the 5 steps or tools or strategies that we can use to help us overcome stigma. It starts with you. It starts with you. The first battle, it's quiet, and it begins inside. Before anything changes around you, something has to shift within you. I like this quote by Helen Keller. It says, "What I am looking for is not out there. It's in me." You have to believe this. Hearing loss does not disqualify you from your dreams. And I'll be the first to say that when I was first diagnosed, that's the feeling I heard. That's what I felt. That my dreams, the goals and dreams I had hoped for, that's the end of it. All the fear that I was feeling inside of me. Am I going to make it? How are people going to judge me? I don't even want to wear a hearing aid. I remember asking the audiologist, is there an alternative? Can I even take a surgery? These are the things I started feeling on the inside even before I stepped out from the hearing center. But I had to hard work to make that shift within. Because it really doesn't make you weak. It doesn't make you less. But keeping everything on the inside can. That shift from silence to strength starts when you stop carrying it alone. So notice the voices in your head. Is it doubt? Is it fear? Is it shame? Write it down and challenge it. Remind yourself, I'm not alone. I still have purpose. I can rise. You don't need to have it all figured out. I used to think that way. I just didn't know if I could even rise again. I probably was having more internal self-talk than I was actually speaking to other people. But when you believe the future is still possible and you're open to help, that's when everything begins to change. Stigma grows in silence, and maybe you're shy or scared or thinking, what if they judge me? What if they don't understand? But here is the truth. The first time you open up is the first step to freedom. Talking to someone you trust, whether it's a therapist, a friend, a supervisor, or a loved one, isn't just about getting stuff off your chest. It's about refusing to carry the weight alone. Because when someone sees you, supports you, and believes in your worth, they keep your hope alive. They remind you that your dreams still matter. And I know this because I lived it. And for me, that person was my wife, Joy, beautiful wife, as you can see. She would sit with me for hours in those days of encouraging me, pouring out words of encouragement. And luckily for me, my wife loves to talk. And in that season, I really needed somebody who would. And when I was finally ready to rise, she was the first to say, let's go. She even drove with me to my first HLAA convention in Florida, all the way from Georgia, and she volunteered to drive. That's what it means when you have somebody who supports you. And the bonus? She did 85% of the talking during the journey, too. And guess what? Today is her birthday. And she told me, Ibrahim, your voice matters. Go. It's okay. She wanted me to be here to attend this convention because my voice matters, and your voice matters. When you find someone who can support you, they can let you know that your voice matters because your voice has power to shift from silence to strength. Someone else who might not be able to do the journey all by themselves. So let me ask you, if you haven't found, who is that one person you can count on, that trusted person you can count on for support? And if you haven't found them yet, keep looking. But if you say, Ibrahim, I just don't have anyone. I'm alone, I have looked, I just don't even know where to start. I don't have that person that I can trust to share deeply how I feel on the inside about hearing loss and about stigma. Well, I have good news for you. Connect with a community. Isn't that why we're all here, right? Because stigma thrives in silence, but community breaks that silence. Because the moment you realize you're not alone is the moment stigma starts to lose its power. So whether it's a church group or a support network or an employee resource group at work, and by the way, I learned about employee resource groups the first time I attended the Hearing Loss Association convention, or a national organization like the HLAA, community offers more than encouragement. And maybe it's something you don't know how to get started. I discovered the HLAA private Facebook group. And I was blown away by the stories that are shared there. And if somebody who is newly diagnosed or is still struggling, you post a comment there. I'm sure you probably get at least several responses with answers, with support, with feedback. And I'm sure there are many other networks where you can find the support that you need in this journey. It gives you the tools, the strategies to navigate hard conversations, the words to express what you're feeling, and perspective, reminding you you're not the only one. I learned this firsthand. 7 years after I experienced the diagnosis, so I learned about the diagnosis. That's when I discovered the HLAA. Until then, I thought I was the only one feeling ashamed, afraid, or confused. I did not know anyone who had hearing loss. I felt like I was in a shell, dealing with it all on my own. I couldn't even express to my family how I was feeling until I found that community who understood. I didn't need to explain, have long explanations. It wasn't needed. And through them, I didn't just find support, I found strength. So, if stigma has made you shrink back or stay silent, start by reaching out. Find your people. It's a strategy and it's a powerful one. So, one of the most powerful ways to push back against stigma is by learning to advocate for yourself. Clearly, confidently, and without apology. My first real experience with this, it wasn't at work. It was at home with my daughter, Gloria. She was just 4. She asked whenever I carried her between the ages of 3 and 4, she would tap on my hearing aids. Daddy, what is this? With the curious excitement, trying to figure out. But I had to explain to her. I hesitated at first. But I explained to her, honey, this is Daddy's hearing aids. They help Daddy understand you better so we can communicate effectively. That's the same thing. That moment taught me something. If I could explain it to a 4-year-old, then you and I can explain to anyone at work, in the public, or anywhere. Something powerful then happened. There was a moment I was talking to Gloria's little brother, Nyake, and she noticed something, and this really amazed me. I kept asking Nyake, what did you say? I can't hear you. In that moment, I did not have my hearing aids on. She asked one of the most powerful questions I never expected. She said, Daddy, can I go get your hearing aids in the room? I was blown away. What I had told her, it sank in. And as a 4-year-old, she ran, got it excited. Daddy, here is it. I turned it on, I put it on, and I'm talking. She's seen me conversing with her little brother, and I was able to understand and respond, and she gave me the thumbs up, right? So imagine in your workplace what is possible. And people are willing to help. I just traveled from a leadership retreat here. And before I went to the retreat, one of the organizers, she knows me. I never asked for anything. She sent me an email. Ibrahim, do you need any accommodation? And I was blown away. She reached out before I even asked. That to me is an indication that people are willing to help. But before, the noise and what I was saying to myself was that if I asked, people would see me differently. Now I'm beginning to see evidence of a transformation that's already taking place. People see with hearing it, they observe, they're willing to help. But sometimes we just have to ask. So it's okay to start small. But when you do speak, whether to a colleague or friend or even your boss, you shift the narrative because you own your story. You're not just breaking the silence, you're breaking the stigma. And that's important. And now to our last point. It's time to rise with strength and purpose. Because I believe we all have goals, we all have dreams, we have things that we want to accomplish. And maybe just the whole idea about the impact of stigma, and you had these wonderful plans that when I retire, I'm going to volunteer, I'm going to do all these amazing things. But now you're wondering, if I do this, what are people going to think about me? I might struggle. You know, stigma may try to write your story, but it doesn't get the final word. You do. Rising doesn't mean forgetting about the pain. It means deciding you would not be held back. For me, rising with strength led to joining the HLAA Board of Directors and also being appointed by the governor of Georgia to serve on my community as part of the Georgia Commission for the Deaf or Hard of Hearing. In those moments, thank you. But when I think about the moments that led to that particular transformation, it wasn't easy. In the beginning, I didn't even think it was going to be possible. I didn't think that I will be able to live out my dreams, my purpose. I was settling for the bare minimum because of everything I was telling myself about stigma and others' perception about me. A lot was happening on the inside. But when you choose to rise, doors open, not just for you, but for others too. You stop seeing yourself as a victim and you start living with purpose. So if stigma has weighed you down, remember this, you are not broken. You are becoming the best version of yourself. You can rise and be the reason someone else finds hope, because it starts with you. And then you get the support and a community. So now if you're asking, what if I'm still struggling? What if you're still struggling? It's okay to feel the way. It's okay to feel all of this, but now you have strategies that would help you move to the next step, to live out your dreams, even in retirement. Because you can do it. You cannot do it all on your own, but you have a community that is willing and happy to work with you. Just connect with them. And so, remember, you're not alone in this journey. You have the power to change the narrative, not just for yourself, but for others walking this road too. So in closing, here's my invitation for you. Challenge your mindset, because how you see yourself shapes what is possible. Step into self-advocacy. Speak up, educate, and ask for what you need without apology. Reconnect with community. A lot of my colleagues here on the panel have shared some of the importance of community and resilience. Because community is your superpower. I like this quote by Mark Hyman. He said, "The power of community to create health is far greater than any physician, clinic, or hospital." Walk boldly in purpose because your story matters. Whether you're working, whether you're retired, or mentoring someone who is just starting out. Maybe your purpose is advocacy, or offering hope to someone newly diagnosed, or simply saying, I've been there too. This is how we rise from silence to strength. This is how we dismantle stigma, one voice at a time, one person at a time. So before we go, I want you to turn to the person next to you and say, today I turn stigma to strength. Thank you very much. Thank you. Thank you. Thank you very much.
Thank you, Eve, as always. And thank you to all of our panelists. We have now the last bit of our time together on this research symposium for a panel discussion and then some Q&A. So I'll start with a question for everybody here. Right, we've talked about stigma is daunting. It's daunting as a society, as individuals, for researchers, on all fronts. So what makes you hopeful about this area of research?
I think it's the people. It's the community. It's also knowing that there are things we can do. And I've worked in HIV stigma for 25 plus years now. And when I started out, it felt like this huge sort of thing that was influencing everything we were doing, and that how were we actually going to get our hands around it? And I think my journey in terms of learning how to actually develop programs that actually effectively reduce stigma gave me a lot of hope. I often hear in healthcare facilities, I work mostly in low and middle income countries, and that a lot of times patients or clients will say, you just can't change health workers. But when you really get in and you start working with health workers, they want to change, and it's often just because they don't understand what they're doing that is stigmatizing. So I think there's a lot of hope in people and in the goodness in people.
Yeah, thanks. Jessie?
I echo that, and that it's the people and their willingness to pass it forward. So on the one hand, in the research capacity, it's having people like Dr. Laura Nyblade, who's coming from a non-hearing loss sphere and passing it forward, the knowledge that she's learned in that sphere to someone like me, who doesn't have the stigma and intervention skills, but is learning them from her. So it's mentorship from, not reinventing the wheel, learning it from people who have done it, been on the ground before. And it's also from people out in the audience too, paying it forward or paying it back to someone like me who's grown up with this stigma and feels the stigma, but then having someone like Eve say, no, it's about strength. So it's not just like, I don't have to keep holding on to the stigma. So learning both from research mentors and hearing loss mentors.
I guess having been in the field for a while, the big thing that I have hope for is the increased awareness of hearing and its importance to health. I think it's important to frame it correctly, and I know yesterday there was a conversation on the different hearing aid technologies, and one of the speakers was very clear about the messaging around the emphasis on hearing loss with cognition and the importance of reframing that in terms of what it really means and the implications, because I get concerned that we sell things for the wrong reasons, but really emphasizing the importance of hearing to communication, the communication at all levels and for interactions and so forth. But there has been just a really humongous growth in the awareness of hearing loss, and it's important to health. So that's encouraging.
Thanks. Ebe?
One of the things that gives me hope is that we even having this discussion. This is a very invaluable conversation, and I feel that education and awareness is key. I think one of our panelists touched on that. It's very important to have these types of conversations. And when you look at it from the perspective of having researchers like my colleagues on the panel here, and people with lived experiences coming together, working together, right? Learning from the research and bringing our lived experiences, we're bridging the gap, we're connecting with people who may not always understand all what the research entails, but they can hear from someone with a lived experience that kind of blends that findings from the research and say, this is how it can work for us, and this is how we can begin to address and overcome it over time. So I'm really excited about this conversation. I think it goes hand in hand with the researchers and with those with the lived experiences.
Thanks, Eve. Next question is for Meg. Some in the audience may not know, and Meg mentioned a little bit, but Meg was really at the forefront of thinking about stigma and hearing loss, and did some of the foundational work a number of years back. And so with that, what in your mind has changed over the years when it comes to addressing stigma related to hearing loss?
It's a really excellent question, because there are things that I think have begun to change, but also some things that stay the same. And again, reflecting on what was commented yesterday, was one person mentioned that stigma seems to be the one area there we haven't made as much of an impact. I know that it doesn't help currently, and it hasn't changed a lot, in that so much of the media around hearing aids and around technologies tend to focus on size and talk about invisible. And I think that's a negative way. I think we need to use hearing aids as a badge of honor to say, I want to communicate with you. And that's why I'm using these adaptive devices, just like anybody else who wants to say mobile, and they'll use a cane. But I think, again, that the awareness and the importance to health has begun to maybe, or will over time begin to sort of eat into some of the issues around stigma. And people can realize that just like having any other chronic condition, this is part of what we live with. And it's true across the lifespan, and keep away from associating it with so much with ageism and so forth. So, yeah.
Thanks, Meg. Jesse, as someone who has hearing loss and focuses your research on hearing loss as well, can you speak to the opportunities or challenges, that you may have encountered thus far?
One of the challenges is that because I study hearing loss, everybody wants to know why I got into hearing loss. So I've had to become very good at talking about my hearing loss, which has been good. It's made me overcome the stigma a bit, but it's taken some time. Another challenge I've faced is sometimes people outside of the hearing, like academics outside of the hearing sciences, don't always believe that there is stigma related to hearing loss. And I need to learn how to push back against that. And that's why it's really helpful to have these kinds of measures that the Lancet Commission created, so we can start to document the prevalence and how prominent of an issue it is, so that I have facts and figures to go back on, because we have qualitative research and I can tell people there is stigma, there is in fact stigma. Like, I can show you the papers that document it, I can show you what people have said about it, but until we have numbers, I feel like there's academics who aren't necessarily as willing to acknowledge the stigma as we all are. And then So that's what then an opportunity is, that we have these ways of measuring stigma now. And again, as I said earlier, having people outside of the hearing loss sphere who do understand stigma, like in the HIV space, and we can learn from them, so we're not reinventing the wheel. I think we have a lot of options moving forward.
Yeah. Thanks, Jesse. Ib, as researchers, we're always looking to fill gaps in knowledge. What didn't you hear about today that you feel like needs to be prioritized when we're working to address stigma within hearing loss?
Well, first of all, I want to acknowledge each and every one of you. It takes a lot of effort to do research, and I really admire the work that you do. A lot was covered today, right? A lot of work was covered today, a lot of discussion. So beginning to digest that is the first thing. I really think that the work that Dr. Nyblade talked about and how in-depth that was done for HIV and having that now in the hearing loss space, diving in depth in that area, I think is important. I think it's going somewhere. I think that the more we can dive and get findings from that and apply it, and we can measure over time the impact of that type of research, I think it's critical. I think it's key in alignment with working together, like I mentioned in my initial feedback. It's going to create a change. And I think that the way we can deal with stigma as we walk along those lines, imagine a world where a lot of people who have hearing loss are really stepping up and using the power of their voice, right? And, they've dealt with it on the inside, that it no longer has strength over them, and walking alongside the researchers with the findings and diving in deep into that type of research and taking the feedback and applying it, I think over time we start to see a change. So I'm excited about that.
Oh, thank you. Laura, so as we've talked about, hearing loss is a newer area for you in your research. What has struck you about your work in stigma in relationship to hearing loss?
I think what has come to me, or what has struck me, so when I was first approached about becoming co-chairing this subcommittee, I was very anxious about it because I know it's a new space for me. But I think what I've learned over the past couple years, and it brings home what I've learned. I've worked, in 30 or 40 different countries and cultures around stigma, and what comes home is that it's a very fundamental human social process that we all engage in. It doesn't matter whether we're talking about HIV stigma, hearing loss stigma, mental health stigma. Stigma is really fundamentally the same at its core. And the differences are really of nuance rather than substance. And I think that was brought home again to me in this transition and in trying to think about what did we learn from HIV, which is an infectious disease, and how would that apply to hearing loss? At first I was very skeptical, right? I thought, okay, I'll give it a shot. But it just kind of brings home that stigma is really the social process that we use to other people, to use our power to put down other people. And it's the same no matter where we're at. So I think that really just was brought home, but also a lot of hope. For me, I was like, wow, you can learn from our mistakes in the HIV field, and maybe you can move stigma and hearing loss much faster to interventions, to actually doing something about it. Because we're 30 plus years into the HIV epidemic, and we still aren't at a place where we should be. And we make little mini steps forward, but I think, for me it was like, wow, there's you can accelerate this much more than we did in HIV.
Thanks, Laura. I want to just ask, as kind of one final question at least for right now, for each of you, and maybe we'll start Ebe and come this way, is reflecting on today's session. What one thing do you want each of us to take away as we consider how to take action against stigma?
Okay. Again, I'll go to education and awareness, and I would go further to say, to encourage everyone, be the first person to educate your family about hearing loss. I think it is very important. If somebody had shared that with me, I would not have been in the shock that I was in when I was diagnosed at the age of 30. During the time of my diagnosis was the first time I heard about hearing loss. I only knew that people could either hear well or people are deaf. And so that turned the light bulb on for me to say education and awareness is important. The more we start to talk to our families about this, the better aware they are, because sometimes it does happen, and they may not be experiencing that level of shock that I did. And I also think in that light, it is important to maybe have something like a hearing loss awareness day in the colleges and universities so that the students will be educated about hearing loss, right? Because there's a lot of technology out there today. There are a lot of wearables that they have on and the impact of hearing loss. So I think raising awareness again for them, or maybe even later, they may experience, maybe mom or dad comes to them and said, I've been diagnosed with hearing loss. What does that mean? How do they support their parents? Or maybe even their child, maybe a newborn, right? And they get diagnosed with hearing loss. It's not a shock to them, but they've learned how to take that with them. And I'll share this because my wife, Joy, she had family members who experienced disability. And so her soon-to-be husband says, I have been diagnosed with hearing loss. And she was able to support me. Even though she did not understand what hearing loss meant, she was able to support me. So I had to educate her, what does hearing loss mean? What are the feelings I'm experiencing? How can she best communicate with me? And that's how she was able to support me in the ways that I shared during my presentation. So I think it's really important if we start by educating our family members, that's the starting point that's going to make a big difference.
Thanks, Eve. Meg?
Well, I think it's exciting now to have measures that we can start to use to really clarify some of the issues around stigma in the different populations. I do think that it's important, certainly in the healthcare field. I think that we need a lot more understanding and awareness of how stigma is manifest in the healthcare system. And I think what Jessica mentioned, that I think people don't always realize that they stigmatize as much, or their various attitudes and behaviors actually exemplify stigmatizing behaviors and having people left out. But I also do think, and it gets to this sort of self-advocacy, I certainly want shared self-advocacy, but we do need to speak out. And I think that acknowledging the fact that you have a hearing loss and being okay about that so that you don't miss out in terms of information is critical.
So one of the key takeaways, I think, from this is that there are people working on hearing loss stigma and trying to intervene on it. So I have a grant under review this week, so I need all of you to be sending all of your best wishes towards that. Let's hope for good thoughts from that. So there are people who are working in this sphere, and we do want to make a difference.
And then Laura.
If you take one thing away from this, stigma operates because of power. It operates in the process, in the context of power, and it's a social process. And we are all part of that social process, and we all have power. So I want you to think about what's your power, and how are you going to use your power to do something about stigma. And there are things that you can do, as you've heard. But remember, you are powerful, and you can do something about it.
Thank you. So, we'll go ahead and open up the floor to questions. There's mics at the front of the room, so please step up, and we're happy to continue this conversation.
So thank you very much for this presentation today. Stigma has been something that's mystified me in terms of hearing loss for a long time. This was very, very helpful. It seems like as a society, we've overcome stigma for glasses and overweight and many other medical conditions, but this one is still around and deeply ingrained. Do you have any insight as to why hearing loss seems to be sticking as a stigma, whereas we've made progress against HIV, we've made progress against people wearing glasses, we've made progress with people who are overweight. Why haven't we made more progress against stigma for hearing loss? Thank you.
I'll give it a try. And thank you for your comments and question. Interestingly, I was asking myself the same question yesterday. It just so happens, why is hearing loss the one that stands out? And the one thought that came to my mind is that it has the word loss in it. And so hearing the word loss, it means I'm losing something. And we constantly reminded that it's loss. You're losing something. And I used to feel that when I was diagnosed first, everyone needed to feel sorry for me because I have a loss. That was my thought process. That's how I was thinking. And so through all this, some of the strategies that my colleagues have shared, and also the journey that I went through, and I had to make up my mind, and I said, it has to start with me. I have to overcome this and not let it have power over me. So I think the word loss in itself, hearing loss, it has a weight that comes with it. And so accepting and moving forward that it doesn't have the power over us to limit us from our potential, to limit us from fulfilling our dreams. And thanks to technology, I have hearing aids today. I am able to do things. I am not disabled because, just like many of you use hearing aids or cochlear implant, you're very competent. You can still do the things that you want to do. And I think it's what we're telling ourselves to really help to shape and to shift the narrative and to let us live a life of purpose.
Yeah, I would say, I will challenge you one thing. I don't think that our stigma related to some of these other conditions have made progress, especially for people who are overweight, unfortunately. But I think in terms of stigma related to the hearing aids, one of the issues is hearing is so critical to communication. And if you're unable to communicate as clearly, and it's not like glasses, at least glasses that are over the counter, they're correcting a distance kind of vision or reading kind of vision. If you have macular degeneration, it's a totally different thing. So it's not really the same because hearing loss, unfortunately, involves changes in the inner ear. And we don't correct those with hearing aids. We don't even correct them with a cochlear implant. There still can be communication issues. So I think it's partly because communication is so central to that interface with individuals and the need for others to be aware all the time of their communication strategies in terms of facing the person. And people forget. It's not intentional, but people forget. So that I think that, and also from my standpoint, from a gerontology, there is that intersection with individuals sort of assuming that it's an indicator that they're getting older, even if we know that hearing loss can occur at any time in life. And so the connection with aging and that idea and disability becomes an issue. But communication, I think, is probably central.
I would just add also that even in HIV, we've not made a lot of progress. But I want to just add on the ageism part, because something that struck me when we were developing these measures and testing them was we had this ageism scale that we wanted to test and ask, and we were working in the US and in Ghana. And we had respondents who said, what in the world are you asking these questions about? We would never think of our elders that way. And I think this society does not value people who are getting wiser. And so I think that's part of it, right? It's that connection, it's that intersection.
Thank you. We'll go ahead. Next here.
I was thinking about glasses too, and I remember being in middle school, and we used to say this phrase, boys don't make passes at girls who wear glasses. And nowadays, glasses are a fashion statement. You see all these ads with these attractive-looking people in their fancy glasses. I have a friend who recently got a hearing aid. She got a bright red one because if it fell into the grass, she wanted to be able to find it. So there is hope. I do have a suggestion for the healthcare field, and that is, why can't everyone wear a mask with a clear center so we can see the mouth and we can understand communications better?
Thank you. Over here.
Yes, good morning. Thank you for an excellent presentation. I'm Cindy Kellner from Palm Beach County, and I have a question and a comment. My question deals with language, and to bring my point home, I'm going to reference something else in my life. 10 years before my hearing loss journey began, my husband and I were blessed with 3 beautiful children, all of whom came to us through adoption. What I just said is very important. I didn't say they were adopted. I said they came to me through adoption. And that's very important to me then and now. The mama bear in me would never let someone say, "Oh, you have adopted children." I always kindly correct them and say, "No, that's how my family was formed or how my children came to me." Because there is still, sadly, a stigma. And like I said, the mama bear won't let my kids be stigmatized. I struggle with my own stigmatization with my hearing loss. And I want to find a way to convey that I have hearing loss, but positively. Never use hearing impaired. That's off the table. I try to smile when I explain, oh, I wear a cochlear implant, I don't hear very well, but I still seem to struggle with how to communicate my hearing loss in a plus positive way. And I'd like your thoughts on that. And my second point is, if there's any way that you can get to the medical community the notion that we need our phones to help us communicate. I don't use my phone to record my doctor for malpractice or anything like that. I'm not recording it. I simply need my phone to understand what they're saying. And down in Palm Beach County, I encounter nothing but difficulty when I try to use my phone in that setting. So I simply ask in your position, if you can relay that's a communication assistance device that we need. So thank you.
Thank you. Who would, anybody?
Well, first of all, of course, I know it's difficult in terms of explaining your hearing loss, and maybe just really emphasizing that, there are changes that make it less easy for you to communicate as well without these hearing aids or whatever. But you need to be comfortable with your own language. However, the point that you made in terms of the equipment in the healthcare system, I really empathize with you. The problem is we have what's called HIPAA regulations, and that's the Healthcare Portability Act or whatever, but it really has a lot of security issues around it. And unfortunately, some of the healthcare systems are especially worried about the fact that most of those adapted, the captioning stuff you have on your phone, go to a cloud or go somewhere. It's not like someone really wants to listen to you. They want to use that information to improve their services usually, but there are some HIPAA compliant systems that hospitals can use. And so I would encourage you to talk to your hospitals or other healthcare providers. Plus, technically, if you say you want to use the thing and it's not, because they worry more about you suing them for having your information up on the cloud or wherever, if you say you need to use this, then technically, in most cases, they should let you do it.
Any other comments? Yeah.
Yeah, for the first question about explaining to the other person, I think the first thing is identifying what exactly is it. Are they talking too fast or not too loud enough? And then it could be something like, I really want us to have a meaningful conversation, an effective communication. Would you mind speaking up a little louder so we can enjoy this conversation? Or it could be, would you mind slowing down or talking slowly so I can better understand you so we can have a more meaningful conversation? I think that's also a positive way to put it.
I know we have questions remaining, but we are like just at our time. Let's maybe take one more question, and then I know all the speakers we're around, we're here, we're happy to stay around and answer more. So we'll have one last question, and then we'll close up the session.
This may not be a good question to end the thing. You made the point that stigmatizing others seems to be a general human trait that goes well beyond medical issues. I wonder if you have any thoughts about ways that we can decrease political stigmatization in our terribly divided country.
Does anyone want to? I don't know. Yeah, Laura, if you have any thoughts.
I'm happy to have that conversation after the panel ends.
Off the record.
So thank you all for joining us. Thank you to our incredible speakers as well. Thank you for your thoughtful reflections and engagement. Thank you to the NIDCD or the NIH for funding this. As you can see, our survey is there. This is key to continued funding in terms of demonstrating our impact, and just want to hear from you so we can make this program better on an ongoing basis. So please share your thoughts with us. Just as we ended on that comment in terms of just, and what Laura has said throughout, is just how fundamental kind of this process of stigmatization is in terms of just to human nature, but what, is even more fundamental, that drive in all of us to connect. So thank you all for joining, and encourage of us to continue connecting and staying engaged. So thank you. Have a wonderful rest of your day.